Thank you.
Thank you, Michelle. Thank you. Yes, thank you so much for the opportunity for us to share a little bit about what our program is. We've done some really exciting, innovative things just in the last 2 years. So we are very excited for this opportunity, and we'll have some questions afterward. We're going to go over some of our general information, embedded programs, and really some resources and helpful tips. And I think, right, 3-part program right here. So we're going to look at the crisis services overview. So Waukesha County has a number of departments, and one of those departments is Health and Human Services. And our crisis program is based out of that department. So we'll talk about what that is in general terms. We'll actually go over some mental health statistics as well, and then talk about our crisis and law enforcement collaborations that we have, and like I said, those helpful tips and resources. So we're going to get things started with a little quiz. So first question here, 1 in blank adults experience symptoms of mental illness each year. Just
5,
shout it out.
4,
3,
2,
10.
1. 7. The answer is 5. Yes,
Yeah.
so 20%. So if you think of people in this room, statistically speaking, that means that one of us would experience a symptom of mental illness. Next question, 1 in blank adults experience a serious mental illness each year.
10.
2,
I would say
25.
So for that we have 20. So what is a serious mental illness? So that would be a mental illness that is so significant that it would impair someone's daily functioning. So it could be a severe depression, it could be a psychotic disorder like schizophrenia, bipolar, other types of mood disorders. Next question, blank percentage of youth 6 to 17 years experience a mental health disorder.
60.
Okay.
Say all of them.
100? 100%?
Teenagers, yes.
Yes.
Raising a few kids, yeah.
Right? So this is 17%. So probably, yeah, a little bit lower than maybe what we thought, especially since we're hearing a lot more of that youth struggling as they've gone through the era of the pandemic. So these statistics were provided by NAMI.org. I do agree with you that the youth one likely is a little bit higher. And really this is countrywide, nationwide data. I know that NAMI is an excellent organization that's always looking for more things to monitor, and they're definitely a solid source of information for us as we inform our programs and use their helpful data. So the last question here, what percentage of law enforcement calls for service are related to a person with a mental illness?
20.
25%.
So I agree with you. The statistics that I found, 10 to 15. Now based on what national source you look at, it could be 1%, it could be 40%. I have a feeling that if we ask any law enforcement officer in our county, city of Waukesha, they are going to say 60%, 70%, because it is that prevalent. So the question I have for the group now is, why is law enforcement typically that first responder in mental health calls? Why would the police interact with a person with a mental illness? Sometimes in danger.
Because nobody else will.
Because nobody else responds. Yeah, all of those are accurate reasons that we see on our end is why the police are the ones who are responding to a mental health crisis. Here are a couple of calls for service as they're coded in their CAD system that are very common every day. These are happening in our community. Welfare check. I haven't seen my uncle in a week. He stopped responding to text messages, he's getting more depressed, he told me that he's continuing to drink or he's drinking more than usual. Police, can you do a welfare check on him? Can you knock on his door? Very common. Suspicious activity. So this could be a person in the community who's calling, maybe they're pushing their groceries outside of Woodman's and they're saying that, there's a person that's standing here in the parking lot. They are just not acting right. Someone needs to go check on that person to see if they're okay. Trespassing, loitering. Someone has been standing outside the sidewalk in front of my business for hours in the rain. They're sitting there, no purpose. They aren't interacting with anyone. They just look a little bit strange. That is a call, as of today, that is a call to the police. Emergency response. My 14-year-old daughter just overdosed on pills. I think we can recognize how that would be a call to 911. Clearly you're going to get an EMS or a paramedic responding to that in addition to law enforcement. And then lastly, mental health evaluation from a hospital, let's say. Person came here for voluntary treatment. Now they're saying that they want to leave. I was just at the HHS board meeting 2 days ago where we were presenting on one of our positions to hopefully get a new ordinance to expand one of our operations here, and there was a committee member that said, why would a hospital call the police? This happens very frequently, whether it's a subject who came there, maybe they are there for voluntary treatment, loved one brought them in, but maybe they don't want to check themselves in anymore. So that hospital feels like they're doing the right thing by calling in law enforcement and having that person evaluated. So why is law enforcement the person to do that, or the entity to do that? That's because of our state laws. Anyone heard of a Chapter 51 emergency? Kevin, who's worked on our inpatient unit here at the county for a long time, is very familiar with this process. So Chapter 5115, emergency detention, also known as a 72-hour hold, is that involuntary mental health hold that by the state of the state of Wisconsin law gives law enforcement the sole responsibility to effectuate that order. So here are the criteria here, 1, 2, 3 of that emergency detention. There's a lot more complex factors that go into these criteria. It's not as black and white, but just real briefly, a person has to have a mental illness and or drug dependency and or developmental disability. That's a treatable condition. Secondly, that person needs to be dangerous to self or others, to the community, to family members, at a risk that is meeting that substantial probability of harm. And then thirdly, the person has to be unable or unwilling to cooperate with voluntary treatment. So the state of Wisconsin says that law enforcement is the sole entity that effectuates these orders, which was a great move for the state of Wisconsin in 2016. Although be it in the county, it was really something that we had to adjust to, is in 2016, these holds are now approved by crisis. So this is the paperwork that's called an emergency detention form. What this law change did, it got the crisis team, which is a 24/7 unit that is operated under the county, involved in the assessment and approval of this process. So crisis cannot do an emergency detention or get someone help involuntarily without the police, and the police can't do that without our crisis team. So the mental health response system in Waukesha County, this is just a general overview of what that could look like and the different people who might be involved or the different entities. So this is non-embedded workflow. In a minute, Lauren's going to talk about our innovative models that are trying to make the system more effective, more resource conscious. So this is a non-embedded workflow, recognizing that every situation is different. We might do an assessment at a school, at a hospital, at a home, etc. Here we start with that person who is in crisis for those reasons that we talked about earlier, that list over on the end. That's a call to either 911 or non-emergency. 911 dispatches that law enforcement officer. They have that responsibility to secure the scene, make sure that everything is safe before they start doing their investigation and gathering initial information. So once they do that, they meet with the person in crisis, we'll talk to that person, gather information from collateral sources, and this really puts the onus of identifying a mental health issue on the officer. And that is what our embedded models do a better job at taking that responsibility off the police. So in general workflow here, we have that law enforcement officer and calling into our crisis team. We're exchanging that information, and then we say, yep, we're headed out, and then we meet that officer to where it is that they are. So potential outcomes of that assessment could either be voluntary or involuntary. So we absolutely work with everybody, with everyone's resources to do voluntary options when we can, whether that be a safety plan or hospitalization voluntarily. If we don't have the ability to carry out a plan, then we would be looking to approve that emergency detention. So you can see these are all the various stakeholders that could be involved just in one crisis. So when you talk about resource-intensive interventions, that is very much a reality of the mental health system. So we have the person who's in crisis, their family, collateral, 911 dispatch, law enforcement, HHS crisis responders, medical hospitals, and then of course psychiatric and mental health providers. I'll turn it over to you to talk about our crisis team.
So this is not all of the crisis team pictured, but a good portion. So our crisis team comprises of, we have 27 professionals on our team, and just really proud of the fact that we have a wide range of experience on our team. So we have individuals that are former law enforcement, veterans, that have prior experience with adult protective services or maybe child protective services. They may have previously worked on an inpatient unit, varying levels of outpatient care. We also have a peer support specialist that works with our team as well. So it's really helpful to have just this wide experience so that we can collaborate and work together to come up with the best type of strategies to help somebody that's in crisis. So our crisis team, the hub for us is based out of the Mental Health Center, and that's right here in Waukesha, just on Airport Road, which Kevin is familiar with. And we are able to be reached during business hours through that first number, and we do accept walk-ins. So that's anytime between Monday through Friday from 8 a.m. to 4:30 p.m. And then we can be reached 24/7, 365 through that second number listed. So what is the role of crisis? So Jenny explained a little bit about us responding out with law enforcement to assess for those involuntary detentions. We have really worked hard to be looking at ways that we can help an individual that's in crisis, regardless if they're maybe meeting criteria for an involuntary detention. If someone's having a crisis, we want to be able to be there on scene as quickly as possible. So we are responding out at the request of law enforcement. If it's maybe a situation that's not rising to the point where an officer is requesting us, but maybe a family is, we can look at a teamed response with maybe 2 clinicians to be responding out. We are answering our crisis line 24 hours a day, and we do get quite a few calls from family members, or maybe it's a community agency or provider that's seeking feedback on, hey, this person is having a crisis, what should I do? And we will walk that individual through some steps, some recommendations, and come up with a plan to get that person the help that they need. We also take referrals from, like I said, community agencies that will also work with us for just that initial follow-up and support. We like to do a lot of ongoing follow-up with somebody that's had a crisis. So what we will do is, after that initial crisis, we'll schedule follow-up calls. Maybe we'll go out to that person's house in a pair and meet with that individual to make sure that they're getting that level of care. We do make referrals to our opiate overdose specialist and then also our youth outreach specialist. So here's some data for our crisis team from 2023. If you see, we've had almost 9,000 calls, and each year that number seems to be growing. Down here you'll see that here's a breakdown of the ages of individuals that we've met with. So it looks like we had the most contact with individuals between the ages of 18 to 24 years old. And then the next age range would be 35 to 54 years old. So over on the right, here you'll see how many calls that our crisis team received from law enforcement overall. So it's almost 4,000 calls. And this is the breakdown of jurisdictions that we have received calls from. So within Waukesha County, there are 26 police jurisdictions that we're working with. Sometimes we do work with jurisdictions outside of Waukesha County if there's a situation that would bring that individual in crisis within our county. So you'll see here that 11% of those calls resulted in that emergency detention. So that's quite low, and that's a really good number because that means that we're working really hard to keep an individual within the community in a least restrictive means and able to get that person connected with community services, or maybe they're going voluntarily to inpatient treatment.
And I would just add that this number, 432 emergency detentions, so that is with crisis coming on scene, working with that person, hopefully not to do that emergency detention. Prior to 2016, when the law changed in, say, 2011, the county did 1,100 emergency detentions. So if you think about that person who, who hasn't made a comment that I could just drive my car into a tree, I could just jump off the bridge right now. Law enforcement in their investigative capacity was very black and white, and they will tell you that that's how they're trained to approach a situation. If they're investigating a crime, if they have evidence a crime has been committed, they have a victim, they have all of these things, that's going to lead to an arrest. Well, if the person made the comment, if they made that statement, we have to take you in. That's very much how that mentality was. So when you think of children as young as 8 years old to all the way up the lifespan, there was a lot of people who were being unnecessarily detained because you were having a law enforcement officer make that decision on their own without the support of a mental health worker on site.
So we were really seeing that there is a strong need for a community member that's having a mental health crisis to get that mental health response. Is it really best for an individual having that crisis to have a police response versus a mental health professional? So we definitely were seeing that law enforcement is spending a great deal of time on mental health related calls. We were also seeing a need to have a faster response for those mental health clinicians to get out on scene. And we worked really hard to look at our workflows and ways that we can embed mental health workers in police departments and the dispatch center to speed up that response. We are also seeing a need for looking at ways that we can identify an individual that's having a mental health crisis that's coming into the emergency response systems. That may be frequent contact with police. They're calling into 911 very frequently or going to the emergency department. And also taking a look at, hey, how can we identify somebody that's getting frequent legal charges? Maybe they're going in and out of the jail system, and that's not the best place for them. It might be because they're having symptoms of psychosis and not getting that treatment that they really need.
So in the embedded workflow now, these are those same steps we showed you just a couple of minutes ago. So you're going to click the slide. We're going to remove those last couple of steps. Click it again. And what these embedded workers do is they get involved at that point of contact. So they are the ones who are helping to identify calls for service that are related to mental health. They get information more directly and more efficiently rather than putting it on the officer to figure out their initial information. Yep, this sounds like a mental health issue. I'm going to call someone to help with this. So it takes away those unnecessary steps or those steps that are in the process now and gets us involved much more quickly. In fact, that we are, as soon as they're clearing the scene in terms of safety, that's when we are arriving in our embedded positions.
Okay, so here's a little roadmap of our embedded positions. So it all started back in November of 2021, and I'm excited to say that I was the first embedded clinician within the Sheriff's Department. So packed up my box from HHS and moved over to actually a little cubicle in the Detective Bureau. So it was definitely, interesting to be, right in the environment with detectives, with the deputies, the patrol supervisors. But it was a really great opportunity for us to build that trust and collaboration with one of the jurisdictions that we're working most frequently with. It was a great starting point for us to really be able to start our embedded pathway. Because that pilot program was so successful, we were able to look into adding a second position. And a big part of that was our crisis team. So Health and Human Services received American Rescue Plan Act funding to start off some 3 additional programs. And then in February 2023, we were able to launch a co-responder. So it's the crisis response unit within the City of Waukesha Police Department. And then in spring of 2023, we were able to embed an HHS crisis counselor within the dispatch center. In April of 2024, so this month, we were able to get funding for an approval for a second shift crisis clinician within the City of Waukesha PD. And then another very exciting opportunity is that we will be having an embedded crisis clinician with the City of Brookfield Police Department. So that's going to be another great opportunity for us to reach more of the county in that embedded setting. And lastly, I just wanted to touch on the fact that our Health and Human Services leadership and within the crisis team, we're constantly looking at data and trends and ways that we can better support the community. So I'm excited to see where things will continue to grow. Okay, so here are our embedded mental health professionals. So you'll see Maddie Savick and Kristen Bauman. So they are currently the full-time clinicians within the Sheriff's Department. So their hours are Monday through Friday from 8 a.m. until 10:45 p.m. So in order to get within the Sheriff's Department, these clinicians have had to go through our DHS 34 crisis training. So that way we are in compliance with the state requirements, and it's a pretty intensive type of training. They are also had to go through an extensive background check to get that badge access, access to the 911 system, it's called NetViewer, and then also to the police system called Spillman. So they have access to all of these different systems to help better inform our response. And they're also working very closely with our crisis team and then the Health and Human Services Clinical Services Division. So it's been really helpful for these embedded workers to be able to see the records from Health and Human Services if there's been prior contacts and just better help support our response. So some of the data from last year, we have had 550 calls for service within this program. So that's quite a bit. They're definitely busy, and some days they're going from call to call. In addition to the 550 calls, they're frequently doing follow-ups. So a good example of this is we had contact with an individual early this year, and initially that person was not wanting to seek treatment, just not at that place of being ready for support and getting that connection. And with Maddie frequently going out to that individual's home, meeting with them and their family, we found out this week that they're actually enrolled in counseling and starting to get that help that was needed. So that's really great to see. Their response time can be as quickly as 10 minutes, and they're traveling separately from deputies. So this is a little bit different than the City of Waukesha program. So they are responding in a Sheriff's Department Tahoe separately from the deputies. And this is very helpful because Waukesha County is large, and if they have a call from one side of the county to the other, they can quickly meet separate deputies that are out on the road. This also gives them the opportunity to, if they're responding to a call and they're saying, hey, deputy, I think I have this under control, we can create a safe plan with family, those deputies can get back out on the road and leave the scene. And that happens about 40% of the time. So what is a typical day like for them? So what happens when you're arriving into the Sheriff's Department? You're calling into the police radio, so you actually have access to that radio. You have a CAD number calling in. You have to get a little bit familiar with what the police codes are, so that's definitely been fun for our team to learn a little bit more about. Logging into those multiple systems. And then taking a look at what type of activity there's been in the county the last 24 hours. So that would be looking at updates from the Sheriff's Department, updates from our crisis team, and seeing if there's any situations that may come back or areas for follow-up. At that point, then you're just going to be waiting for activity in the community. So they're scanning that net viewer system, listening on the radio, and if they hear a mental health or substance use related call, that's when your ears are going to perk up and either self-dispatch, so call into the radio and start to get out on scene, or maybe the deputy's on another call and they will request that the mental health professionals respond out. And at that point, when they're out on scene, that's when they would decide, hey, is this something that deputies should stay or should we relieve them? Another additional thing that they're working on is attending those roll calls so that they can build relationships with deputies, they can provide mental health updates, and they'll go from the different substations within the county to do that. And then at the end of the day, they're logging off and signing off on that police radio. So here we have our City of Waukesha Crisis Response Unit. So right at the top we have Anna Diaz and then Officer Sunny Schneider. So these clinicians within City of Waukesha PD, that model is co-response. So they are riding with that officer to the situation. So where that can be helpful is that they are getting out on scene as quickly as possible with that officer. And it's helpful in City of Waukesha just with the condensed area. A good example of that would be, let's say that a call comes in through 911. We have an individual that's maybe acting disorderly in the street, and Anna's riding with the police officer. She can look at our system and say, hey, oh, that person may have missed their last 5 mental health appointments. We're familiar with him, and be able to provide that immediate support and de-escalation. And maybe this is a time that they're able to get that individual back home versus maybe a disorderly conduct charge. So the hours of the program are Monday through Friday from 10 a.m. to 6 p.m. So Anna also has access to the police radio, and she is wearing a protective vest because she's riding in that car. They are working very closely with Waukesha Memorial Hospital so that they can provide best practices in client care and look at situations that, hey, maybe this could be figured out with our crisis team before police are being called out. So City of Waukesha PD and the Crisis Response Unit are having regular contact with the hospital to work on those things. They're doing frequent community engagement and education. Some of their service for calls in 2023, it looks like it was 383. So they are very busy as well.
Mm-hmm. Can I ask who has heard of this unit? Has anyone heard of the Crisis Response Unit already? Okay. It's gotten a lot of great publicity. The picture down at the bottom there is Chief Thompson, that's Officer Fink, and then our other crisis supervisor, Mariam Fatirion. This was a highlight of the mayor's breakfast last August. And I'll say it's because of great PR opportunities like that we have been expanding. You've seen that roadmap. I happen to know that the City of Brookfield mayor was at that breakfast, and that was at the time where we were talking to the Brookfield Police Department. If you were taking note, if you could see all those different graphs, Brookfield was that top third law enforcement agency that works with us right now. So it was a great opportunity, and so we're just really grateful to get this information out to the community level.
Okay, and lastly for embedded. So like I mentioned earlier, we now have a crisis counselor. It's actually 2 crisis counselors that are sharing that role within the 911 dispatch center. So what the roles and responsibilities are for the crisis counselors is that they are joining those first party and second party suicidal calls, or maybe it's a well-being check. And so the dispatcher within the comm center, they are owning that call. So the dispatcher is still that main call taker, and then the dispatcher will, what they call, barge in the crisis counselor. So at that point, the crisis counselor can provide some immediate support. They can speak with that caller for a well-being check and maybe get some additional information that the dispatcher might not have known. So it's really helpful when we can look at our systems and maybe we're familiar with that caller and help that person more immediately. They're also looking at all of the calls for service and taking a look at, hey, is this a situation that our crisis team should be alerted on? So we've been really working hard with the police jurisdictions to call the crisis team if it is mental health or substance use related, but that doesn't always happen, and this is a way for us to be more proactive in that. So if we see that, an individual that we've been getting calls on from maybe family or providers is having a situation in Pewaukee or Oconomowoc and they're having police contact, we can reach out to that officer and ask that they connect with our crisis team. And our crisis team over at Mental Health Center can start to get packed up and ready to meet that officer out on scene. So it's a really great way for us to look at how can we help this person that's in crisis and maybe avoid criminal charges or further contact within the next few days. They're also taking a look at data and trends that are happening within the community. If they're noticing that there's a certain facility that's having more contact with the crisis team or police, they're taking a look at those types of things. So another area that we have seen a major need for improvement is our emergency detention process and the time that is spent for law enforcement on those types of calls. So like Jenny mentioned, when somebody is placed on an emergency detention, they are involuntarily going to the hospital, and behind the scenes that can cause a lot of time for that individual being at the hospital. So they could be getting that medical clearance treatment, and it could take anywhere from a few hours to longer, and then it's still some time for them to get admitted to that psychiatric unit. So what we're doing is having that crisis clinician call the ER, call the hospitals, and find out what the time frame is, and are there ways that we can better look at how to improve that.
So when Lauren says a lot of times, she's absolutely right. We've actually just started to do a data time tracking process on these emergency detentions. So those boxes that we all showed, that kind of general workflow, what we are seeing is that takes an average of 10 hours of time. 10 hours from the time that that officer first makes contact with that person, with the crisis assessment, with approval, the medical clearance. Someone has to go to a hospital to get medically cleared before they go to a psychiatric room. And that's where then the law enforcement officer kind of releases that person to the custody of the psychiatric unit. That is 10 hours for a non-complicated emergency detention. So there's no ingestion, there's no injury, there's no UTI or other complicated medical issue. That's 10 hours of time. And that's definitely something that we know needs to get better, mostly for that person in crisis, because what we have seen is that person who's having symptoms of paranoia or mood irregularity, they're getting more amped up. They're in an emergency room, it's busy, it's loud, they got officers standing right next to them, maybe they're handcuffed to a bed. Like, that's just not how a person who's having a mental health crisis should be treated. So if you or someone you know is struggling with mental health, the message that we want you to take away today is just please reach out. Our crisis program is available 24/7. We have a couple of items here that you're welcome to take, so you always have our number. So like Lauren said, we have a call line. We can go mobile 24/7. So what you can expect if you do call our line, we are going to gather information. It's possible that we could do a risk assessment if we determine that there's some type of immediate need to assess for. We can also discuss voluntary and involuntary interventions, so we can take calls from anyone in the community. We can take calls directly from people who are looking for assistance themselves, but also family members, friends, etc., really anybody. And if the person that you're calling about is not in Waukesha County, we can still help with either connecting you with another crisis program. In the state of Wisconsin, crisis services are actually mandated. So 988, who's heard of 988? couple of people. So that is the National Suicide Prevention Lifeline. So there's federal legislation that came out 2021 that they wanted a 3-digit number similar to 911, similar to 511, 211. That was a easy to remember number to get connected to the National Suicide Prevention Lifeline. So that's also a resource for you. They would provide phone support. They don't provide any type of mobile response, but they can definitely triage with emergency response if needed. Resources for persons who are supporting a loved one or a friend with mental illness. NAMI Southeast Wisconsin is an amazing resource. Used to be NAMI Waukesha, just off of, where are they, Main Street here, Broadway. That they've moved locations and they've also expanded their region. They now work with Milwaukee and Jefferson, so that is why they're rebranded Southeast Wisconsin. But they're just a very helpful nonprofit agency that can provide information, referral. It's really for that person who has a loved one with mental illness, because that can be a very powerless space. It can be a very helpless space. They have a lot of support groups for education about mental illness and really how to support a loved one who's going through a condition or going through treatment, and advocacy as well. They have a really great resource that they put out called Navigating a Mental Health Crisis. If you just Google this, you'll get this 33-page PDF document. So for loved ones, if you have someone who's struggling with a mental health condition, maybe the best time to engage with them on a plan is when they are doing well. So things that you might talk about with that person, and what this plan really guides the reader through is you might talk about warning signs. So someone might say, I know that I'm not going to be doing well if I don't sleep for 3 days, or if I have more cravings to drink, I know that I'm going to be in a stressful spot in a couple of days. When to think about going to a hospital. So again, that could be symptoms related to low appetite, it could be sleep, it could be I'm thinking about harming myself, I'm thinking that I don't want to wake up tomorrow. Those would be reasons why you might go to a hospital. When to consider calling 911, and also who could be involved and who not to be involved. You know, Aunt Betty's really helpful to me when I'm in my darkest moments. Uncle Joe is not. So just having those conversations about who you would want or who that person would want around you when you're experiencing a mental health crisis. Techniques that may de-escalate a crisis. Can't say specifically enough that keeps stimulation level low. We do see how everyone coming to the scene, everyone involved, sometimes we have to diffuse that situation because there's just too much going on, and that can add a lot of stress to the situation. So keeping your voice calm, avoid overreacting, listening to the person, expressing support, concern, avoiding continuous eye contact, ask how you can help. That stimulation factor, I think if there's going to be a top one of these, that would be my suggestion. Moving slowly, offering options instead of trying to take control, being patient, gently announcing actions before initiating them, giving them space, don't make them feel trapped, don't make any judgmental comments, don't argue or try to reason with them. And when we were talking with Michelle and Karen to prepare for this presentation, it sounded like they've had some encounters where maybe you see someone on the side of the road and you don't know, should you engage with that person, should you not? I don't want to be in that position to tell you what you should or shouldn't do, even if it's, I know there was one conversation, oh, should I just take this person in my car and drop them off somewhere? Your safety is key. If something is not feeling right to you, don't do it. Don't feel like you have to be that do-gooder that's going to put yourself at risk, maybe put that person at risk. I think if you are interested in offering that person help, keep space. Say, can I help you in some way? Can I make a phone call for you? Is there some type of help you need? But really rely on professionals like law enforcement, like your mobile responders, to help navigate that situation. So there's I don't want anyone to feel like they would need to kind of put their own safety in jeopardy if they're in that type of situation. And then lastly, helpful tips. So if you have to call the police for a mental health matter, you can inquire about the availability of a CIT trained officer. CIT training is Crisis Intervention Team training. It's based out of Memphis, where in that jurisdiction, that city, years ago they developed a 40-hour curriculum for police officers that they learn about mental health conditions, they learn de-escalation skills. So it's not the place of a clinician, a responder, like a HHS crisis responder, but they have specialized training in how to identify a mental health issue, how to work with someone who has a mental health crisis. You can provide the person's diagnosis if known. Dispatch will likely ask for a physical description. This happens a lot in our area. If we're working with someone, they leave the building, but we weren't quite sure if they were going to be safe. We have to give a physical description of what that person looks like. Provide information that could assist in de-escalating a crisis, and also what wouldn't help in a crisis situation. So the person could tell dispatch to relay this to the officer. He prefers being called Jimmy. He likes writing poems. He likes listening to music, and provide what has helped in the past. Provide information on if there is history of aggression, violence, any access to firearms. And then lastly, I'll say that unfortunately, this is the reality, but once 911 has been called and officers arrive, that caller really has no control in that situation. And I think that's something that when we hear calls on our crisis line from families, they're very much in this position of, I want to see my loved one get help, but they could feel very guilty. They could feel very torn with making a phone call to the police or to a crisis response unit for an intervention, because you really lose control once you have law enforcement on scene. Like I said, law enforcement is trained to address immediate safety. So if someone's hearing voices, they're saying, take your hands out of your pockets, take your hands out of your pockets. You can't hear that law enforcement officer. The officer is going to try to be directive and try to approach that situation as calmly as possible. But that's where we see oftentimes law enforcement and a person having a mental health crisis not coming up with that outcome, that goal of de-escalating. In fact, it kind of escalates the situation very frequently. And that is all we had. So any questions or comments? Yes, Larry?
Just like not enough people know about your program.
So yes, our Crisis Resource Center is on Airport Road here. We have our mental health center building. Lauren showed a picture of that. So it's not inpatient level of care, and inpatient is that most acute level of care. We have, it's a locked unit. Psychiatry, oftentimes people might need to be on a one-on-one there because of safety precautions. This new level of care is subacute, so a person who's having a crisis could go here. There's staff trained, mental health trained 24/7. A person's free to go to appointments in the community. What they receive there is a safe space. It's a home-like environment, so something that feels much more comfortable than maybe the sterility of an inpatient unit. And it's really meant to address their immediate situation, get them connected to a resource, and then they continue on in their community. It is short-term. We actually just have a really great example as of yesterday. 20-some-year-old male lived in a supported apartment, has a developmental disability. He got into an argument with his roommate. So in the state of Wisconsin, when you get into an altercation and the police are involved with someone that lives at your residence, that is a mandatory arrest. So we worked through a plan with the jail to actually keep him until the following day, where we could reach out to his managed care organization, kind of his network of people, his guardian. He still didn't have a place to go. He couldn't return to his group home because of a 72-hour no contact order, which is also part of a mandatory arrest law. So this kid has nowhere to go. He has been deemed incompetent because of his developmental disability, and there's really no other group home option for him. So our Crisis Resource Center was able to admit him overnight, and some of those things about, how to keep him calm during a crisis, all of that. He listened to Michael Jackson on our unit for a couple of hours. He had a home-cooked meal from our CRC providers. So things that really just helped to keep him calm, that he didn't require the level of an emergency detention, of going to a medical hospital and taking up a medical bed there. So he was able to be admitted to our Crisis Resource Center and actually then discharged today because the group home was able to find him another spot, readjusting some of their other residents' units. So it was just, yes, a beautiful way that we wanted to, we knew that we needed this level of care. And it's stories like that just really make us really... Yes, you're absolutely right. In fact, today we had a call where we assessed a woman, alcohol-induced dementia, was at a care facility, but she was getting violent. She was getting aggressive. This was a new facility for her. She had just been admitted on Sunday. So we did an evaluation for a chapter. We could recognize that this is a woman who just moved into a new living arrangement. She was getting more agitated when medication was offered to her. Do we think that the best thing for her, while she was violent, she pushed a staff member, do we think that the best thing for her is handcuffs, back of a squad, and then off to a psychiatric emergency room? No, because we have a great relationship with our ADRC, our Aging and Disability Resource Center, which if Plowshare is interested in learning more about county services, I would definitely recommend the ADRC. They have a lot of services. They have dementia care specialists that have helped to train our crisis team on some of those helpful tips and tools for working with someone who has dementia. So even just making sure that, prior to any type of challenging behaviors, is the person in pain? Are they too cold? Are they too hot? Are they able to communicate in a way that they're uncomfortable? Do they have any comfort objects? Can you talk with them about what really calms them? Is it a history of law enforcement officers? So you talk with that person about being on duty and kind of engaging in their story. There's a lot of ways that we can try to offer, and suggestions to staff about routines and who's involved, to try to really minimize any type of involuntary intervention for that population.
And I think a lot of education too to the family members or the staff about what it really looks like if that person were to be placed on a Chapter 51, because it's going to be extremely traumatic, and we're providing a lot of that immediate education on what that process would look like, and then those support tools for how can you help de-escalate.
Do you think the laws need to be adjusted to deal with that situation? Because from looking at the outside, it looks like you just look at it face value, you guys.
I would say if it's law or if it's some other type of regulation, but just seeing how, and we see this with our group home population too, just the lack of training that's required, or just the support maybe given for those regulated facilities, where oftentimes they do use the police or a chapter as they think it's that ticket to get that person out of here, because man, are they challenging. And on the end of the staff side, of course, who wants to be pushed and kicked and harassed? So there's definitely a part where we kind of see all angles. So whether it's a law change or other support, something, I think that yes, that's definitely something that we're preparing for as the state ages, and we're getting more of those calls.
Your program has done wonders for these issues. But one other one that I see that we need to improve on is the AODA issues.
Right, and that is something that I would say that's where our laws really work against us as well, in terms of that alcoholism, for example, very criminalizing. We do have drug treatment court, alcohol treatment court, or if someone comes through that criminal justice system, they do have treatment options. I'll just say on the topic of alcohol, our laws in the state are really much different than the rest of the country, and even though alcohol is that drug that people in Wisconsin die most of, there's really not a lot of political support to try to intervene in ways. So for example, there are holds that can be done for a person with an alcohol use disorder. Those have much smaller timelines. They have much less of a chance to do any type of extensive work, and that is just the reality of state law in Wisconsin.
I saw one thing you had up there about an opiate response. Can you explain that a little bit?
Sure. Through some grant funding that we have through our clinical division, we have a person who is an opiate overdose prevention specialist. So we have a number of grants that could pay for the treatment of a person who wants to access treatment, whether medication-assisted therapy or residential level of care. We have a lot of options of treatment for that person that could get paid through some of these grants. We have done a lot of work in our fentanyl has also been kind of determined to be declared a crisis here in our county, across the nation, across the state. We have oak boxes that we're putting up, Narcan or naloxone trainings. So that person is a contact person that in our line of work, if we hear that there's been an overdose call, non-fatal overdose, we're to give that person's information to this outreach person. They can meet with the person at the hospital. They could make a phone call to family members, friends, and try to get that person or their loved ones connected to resources.
And they do have a dashboard through Waukesha County that shows where all of the oak boxes are. So that's a really nice option for a loved one to be able to go on that site and say, hey, there's 3 in my community, or 1 over there.
An oak box, yeah. Oak kit, OAK is Overdose Action Kit. They are, I believe, a national model. They're red boxes, about 1 foot by 1 foot, and inside you would find fentanyl testing strips, you would find naloxone, you would find plastic gloves. So that would be for if someone around you, or if someone that you know has an opiate use addiction, that you could potentially administer Narcan, which is a nasal administration, if they have overdosed on an opiate.
Job. Is there services that you have for your employees to help through certain stressful situations?
Yeah, that's a good question. I would say that it definitely takes a certain breed to do this work. We've seen the people who like feast or famine work, the going from call to call, that seems to be the person that does well in this job and is fulfilled by it. I wouldn't say we have any additional resources.
No, I would say that we work really hard to just have an open feedback culture, where if it is a difficult day or you're going on a tough call and you need some time or space to process through that we're able to communicate that with each other. We don't know what we're going into each workday, and we're really lucky to have a team that fully supports each other in that, and that constant debriefing processing is really important for us.
Yeah.
Benefit is the work that you're sometimes able to do with first responders. We're also in a very high stress situation. Could you just talk a little bit about that? Because I thought that was a wonderful thing.
Yeah, I might let Lauren take that one, because in her role she saw that directly.
Yeah, I mean, that was definitely an unintended thing that we saw in the embedded positions, is that we were just seeing, having mental health professionals at the Sheriff's Department specifically, that it was opening up the doorway for those conversations. We like to have like an open door policy there where the mental health professionals, they have snacks and candy and drinks in their offices that the deputies will frequently stop by and chat with them, and even if it's like an informal hello, they may share a little bit about a challenging call that they were on the prior week. And then that's when the conversation can start about, hey, are you using the employee assistance program? There's this other resource. So we've really been able to start those conversations and see that there's such a need for it. And if you take a look at some of the data, there unfortunately are a lot of suicides by first responders. So it is something that's very important to me and our team that we're aware of.
There's a place right on St. Paul, or not. And you had a question?
Yeah, do your teams get called into the schools, or do they have their own teams that?
It's definitely a daily, if not, more than that occurrence. And we definitely see, situations where it may be one youth that we're seeing more frequently, and then we help support that family until they're more stabilized. But yes, our school calls are actually fairly high.
So we have kind of developed our relationship with schools over the years, in that there certainly are a lot of in-house resources, guidance, IEP plans that need to be followed. We definitely go to schools for assessments. We also help maybe do some coaching on kind of setting up a supportive environment for that student, for that youth, and kind of working with the family. We might do follow-ups with the family outside of the school day, and really try to make sure that when we are getting involved, that all other resources have been made available, or even a call to the parents have been placed. Because sometimes what we were finding is a student would come in, say, I just feel like I don't want to live anymore. That would be a call to crisis, and a county crisis worker would be coming out there without even involving the parents, and that's clearly not the right approach that we would want.
Thank you.
Mm-hmm. Yes.
Can you just quickly talk about the correlation between mental illness and addiction?
A lot of substance use related issues are because of an untreated mental illness. We've also seen a lot of overuse of substances to the point that it looks like a psychotic disorder, but once that person is actually sober, they haven't used, that's not really part of their presentation, and it's very difficult to treat that. I would add that oftentimes trauma is a part of that. So whether you're dealing with some PTSD symptoms, or a mental illness that would benefit from psychiatric medication, it's really challenging to I think make decisions on that in the moment, as in terms of safety, but then also really working with the right providers and making sure that whether it's the family member or the friend know that they have treatment options if it appears that that person isn't successfully going through treatment. Do you have anything else to say about that?
I would say that a great deal of our calls have some type of substance use component, and we're seeing that there is that mental health piece as well. So I would say it's fairly common that there's both involved.
Yeah.
It wasn't a public nuisance, but it was like,
I think on when we were showing the slides about what our comm center
Yes.
position, disorderly conduct,
disorderly
maybe?
conduct. What all falls under that?
That's a great question. It seems, so that is a crime. An officer is going to be the much better profession to explain what that is. But what we have seen on our end is if it's like a public nuisance call, I know that there's been a lot of activity in this area where maybe someone is shouting at the top of their lungs, maybe they're harassing people. That could be considered disrupting the peace, and what we have seen is that is a charge. If someone's going to be taken to jail, that usually a disorderly conduct or a DC is that charge.
And I'll also add, we see a lot of kind of domestic situations where maybe it's an argument between two spouses or a family member, and it comes in as a disorderly conduct. And when we take a look a little bit more at the call, it may be because that person is struggling with substance use or mental health, and it just started to get to the point where the other family member is feeling unsafe, they've been threatened, and it comes through as a disorderly conduct.
And that's one of the, I would say, one of the most common charges that we have seen a person with a mental illness be charged with. Because if you saw our criteria for that emergency detention, it's very high. Immediate dangerousness, mental illness, substantial probability of physical harm. The threshold for disorderly conduct, and even though they're civil law, this is criminal law, but the threshold for that charge is much lower. So that is where we see, that's why 60% of the jail population right now is struggling with a mental illness, because it's a lot, I'm going to say easier, but it's really the safety net that the public system has, the public service system, meaning law enforcement, has to address that situation.
Yeah. An example that I'm thinking of is, an individual, I think he was in his 50s or 60s, and through the embedded role, I could see that this person had likely a dementia diagnosis, but he was getting repeat disorderly conduct charges and ending up in the jail and not doing well in the jail because he really didn't belong there. So we were able to intervene with Adult Protective Services and have him placed on an emergency protective placement where he could get long-term care and that treatment that he needed versus going in and out of the jail system.
So that's because I was thinking, so when it happens, that the police are there, so that.
Exactly. And we're talking about expenses. I don't want to make a number up, but the cost of getting a person into treatment versus housing a person in jail repeatedly, or potentially where we've seen low-level disorderly conduct charges land, is if that person isn't competent in their criminal proceedings, they could sit at the jail for months as they wait a bed for criminal competency through the criminal justice system. So a lot of complex factors there, but we have seen how something as small as stealing a banana at a Quick Trip and being a little loud in the parking lot has meant months in jail and getting that person eventually to Mendota. Whereas if we could have intervened, maybe it was someone who was open to one of our case management units. What if we could have said, let's take you to your appointment tomorrow. Go to the CRC, we're going to get you to your psychiatry appointment in the morning. That is going to be more cost effective for the systems. It's going to be the better care for that person rather than being locked up for months.
Would you say over my ear on the side of thinking, oh, gee, maybe this really is a mental health thing and seeking that assistance rather than just...
Definitely, yeah. I think that they have gotten, and definitely not talking badly about the law enforcement profession. I think City of Waukesha is probably a good example where they know something's not right. Maybe they don't know the diagnosis or what type of treatment the person needs, but they can tell that, yep, that's the person that we see every day in the park. He talks to himself. He gets a little loud. Hey, how's it going? No, I'm not going to take your, just keep your liquor away. Like, they know that something's not right. I think what the beauty of our collaboration most recently has been is we can help with that. In the past, that they didn't think that there was any intervention or any way that anything could, that there would be any assistance, but now that we are right on site with them, they don't have to wait 30 minutes for us to come on scene. That's where they're making those connections more and then helping to get that person into a different spot than just kind of recognizing that that's the way the person is and that's the way that they're going to be.
And those conversations are happening much more. It's been really cool to hear from the embedded MHPs that the patrol lieutenants are wanting to hear more about what the criteria is. They'll talk through, if this case was an emergency detention or a safety plan, they're pulling in Maddie or Kristen and wanting to go through some of those steps and learn a little bit more. So that's huge progress.
I would say we learn just as much from them as they've learned from us, just about police culture and why cops come across the way that they come across sometimes. So it's been mutually beneficial.
Situation to work some of that out, and then hopefully I would guess the idea is to do a soft pass off to an agency that can help this person.
So yes, you're absolutely right, that's where we see, particularly that person, let's say that, that guy that stole a banana when he was having a psychotic episode, now he's got a criminal charge. So is he going to be allowed into one of the shelters? That person that got a little aggressive with their, their resident neighbor, disorderly conduct charge. We can't take that person now here in our shelter. And then we see how that really just compounds the system, that there's so many barriers for people who are unsheltered, whether they just don't have, sure, apply for the housing list. Well, we need your social security card, we need your identification. Oh, well, that got stolen from me when I was sleeping out in the woods one night, or I didn't get that back from jail. Like, we see very much how there's so many barriers, and we just kind of think, well, there's housing, get a job, there's housing resources all over, go to the shelter. It's really not, that's not the experience of people who have who are in that situation. So absolutely, I know there's a lot of work that we're trying to do with the unsheltered population. I would say that's a number of people that we have seen already at our Crisis Resource Center. We do want to preserve that space for mental health crisis. It's not just a homeless shelter, you don't have anywhere to go. It really is, that person would need something in that moment. Otherwise, they are going to have attention with the police. They are going to be going to a hospital, something like that. So it's been very much as we get each referral, we're very much, applying some of those standards to everyone that we're screening, just to make sure that they're appropriate. But you're right, it's very much a challenge. Yeah, and thank you for your work in that. Mm-hmm.
No, it's a group effort.
Mm-hmm.
Well, if there are no more questions or comments, I want to thank you both so much, not only for the presentation, but for the work that you do.
Mm-hmm.
Bravo.
Thank you. Thank you.